Extract 1. Questions 1 to 12.
You hear a doctor talking to a patient. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Yes, good morning. What can I help you with today?
Doctor, I'm getting a throbbing pain in my right shoulder.
How long have you been experiencing this pain?
For the past 5 months. But the pain has worsened in the last 2 months. The pain aggravates as I'm a regular baseball player that involves throwing. Now I am also participating in basketball.
What is your age?
21.
Oh, I see. Do you take any medication?
I was taking non-steroidal anti-inflammatory drugs and muscle relaxant medications.
Are you allergic to any medicines?
No, doctor.
Have you had any surgery or any diseases?
No.
Do any of your family members have any diseases?
Yes, my mother has arthritis.
Do you drink or smoke?
No, doctor.
Well, your blood pressure is 116/68, respiratory rate 16, heart rate is 68, and weight 165 pounds. Your right shoulder shows evidence of swelling and tenderness. Radial pulses are 2/4. Bilateral. Brachial pulses are 2/4. Bilateral. Range of motion of your right shoulder shows decreased flexion, decreased extension, decreased adduction, decreased internal rotation, decreased external rotation. Left shoulder is normal. External rotation is fair. Internal rotation is poor. Rotator cuff impingement is moderate. Your X-ray report reveals presence of cuff arthropathy. You have developed rotator cuff syndrome in your right shoulder. Actually, the rotator cuff is a group of muscles and tendons surrounding the shoulder joint. A rotator cuff injury causes a dull pain in the shoulder and often worsens when you try to sleep on that side. Often, rotator cuff injuries occur in people who perform overhead motions repeatedly in their jobs or sports. Without treatment, rotator cuff injuries may result in permanent loss of motion or weakness, which may result in progressive degeneration of the shoulder joint. Although resting your shoulder is essential for the recovery, keeping the shoulder immobilized for a long duration can cause the connective tissue to become thickened and tight, a condition called frozen shoulder. I am prescribing you Vioxx 25 milligram tablet once per day. I am giving you an injection to your shoulder joint with Celestone Solispan 1.0 cc. If the condition is not improved within 15 days, then I would order an arthroscopic tendon repair in which a tiny arthroscope and tools are inserted through small incisions to reattach the torn tendon to the bone.
Extract 2. Questions 13 to 24. You hear a sleep specialist talking to a new patient called Georgia Douglas. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good afternoon, Mrs. Douglas. Your GP has sent you along to see me today because of some problems you're having sleeping. Is that right?
That's right. He says I've got RLS, restless leg syndrome.
I see. Well, I've got some notes here from your GP, but can you tell me in your own words how long ago this started and what's happened since then?
It all began about 18 months ago. I got this strange sensation in my legs. It was like a burning feeling, not on the skin, but inside the legs, in the muscles, and it was really uncomfortable.
Mm-hmm.
Then after a few weeks, it was as if there were insects moving about inside my legs. Oh, it was horrible.
Yeah.
I was fine during the day, but it started up every night as soon as I went to bed. And then it was hard to get to sleep, what with this funny feeling in my legs.
Did anything help to relieve the feelings you had?
What made it better, at least for a few minutes until it started again, was moving my legs.
Mm-hmm.
But it got to the point where I just had to move my legs. It was uncontrollable. That's the only way I can describe it. Eventually I'd get to sleep, but not until 2 or 3 in the morning. And my husband said that even then I was moving my legs at very regular intervals. And that kept him awake, of course. He'd lie there waiting for the next time I moved. It got us both down, and I was more and more tired. And colleagues noticed that I was sleepy at my desk. I'm an accountant.
Mm-hmm.
One day I even nodded off in a meeting. Someone had to nudge me to wake me up. It was very embarrassing. So eventually I just had to go to the GP, who said it was RSL.
Right. And did your GP give you any advice on what to do?
Well, he said to try to keep cool at night and use light cotton sheets rather than heavy blankets or a duvet. I'm not sure that has made much difference, though, because I certainly can't sleep if I get cold. The other thing he mentioned was doing some massage. I mean, I do it myself, and it does help to reduce the feelings. I do that before I go to bed each evening. But I can't do it whilst I'm asleep.
Mm-hmm.
Oh, and I've been relying more and more on black coffee and energy drinks during the day to help me stay awake. And he said to cut back on anything containing caffeine if I wanted to get a good night's rest.
Mm-hmm.
But then he also did a blood test for iron deficiency, because he was talking about putting me on tablets for that. But the blood test was fine, so that's not the cause of all this.
I see. And how is your health generally?
Fine. I don't smoke, and I'm not overweight or anything.
No.
At some times of year I use antihistamines, because I get bad hay fever. It's the pollen, you know. My GP asked me if anyone in the family had ever had the same problems, but I don't remember anything like that at all. Although I mentioned that my father had type 2 diabetes, and he did say that there's sometimes a link there, but he checked and I'm not diabetic.
So what are you hoping that I can do for you?
Well, that you'll be able to suggest something to help, because I'm just feeling so tired all the time, and my husband's fed up with it all. I mean, perhaps I need to take sleeping tablets. Also, I saw online that there's a place called a sleep clinic you can go to just overnight, and they look at your sleep patterns to see what's going on. When I mentioned that to my GP, that's when he suggested I come to see you.
That is the end of Part A. Now look at Part B.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear a discussion about different types of kidney cancers. Now, read the question.
Hello, doctor. Can you brief me about different types of kidney cancers?
Well, like any other cancer, kidney cancer starts when the normal cells in one or both kidneys mutate and grow aggressively, forming a tumor or mass, which can be benign or malignant. Kidney cancers that have originated elsewhere and metastasized to the kidney are clear cell adenocarcinoma, transitional cell carcinoma from the bladder, renal lymphoma, inverted papilloma carcinosarcoma, teratoma, and carcinoid tumor of the renal pelvis. Renal cell carcinoma is the most common type of kidney cancer that accounts for 80 to 85% of all cases. This develops within the microscopic filtering systems of the kidney, which are the tiny tubes that carry the urine to formation. Transitional cell carcinoma, also known as urothelial carcinoma, usually begins in the area where urine collects before moving to the bladder. Pathologically, this cancer is similar to bladder cancer and is treated like bladder cancer. Kidney sarcoma is a rare form of kidney cancer that is usually treated with surgery and chemotherapy. Sarcomas may be large and usually does not spread. Wilms tumor is a common type of kidney cancer that occurs among children and is treated differently than kidney cancers in adults. Common treatments for Wilms tumors are radiation therapy and chemotherapy. Squamous cell carcinoma, juxtaglomerular cell tumor, or rananoma, Bellini duct carcinoma, mesoblastic nephroma, mixed epithelial stromal tumors, or other types of kidney cancers. Question 26. You hear the discussion between 2 doctors about types of perforations during endoscopic retrograde cholangiopancreatography. Now, read the question.
Doctor, can you explain the types of perforations during endoscopic retrograde cholangiopancreatography?
Well, although perforation is an unusual complication of endoscopic retrograde cholangiopancreatography, the diseases of the duodenum and common bile duct can increase the risk of perforation during endoscopic retrograde cholangiopancreatography. There are 4 types of perforations during endoscopic retrograde cholangiopancreatography based on etiology and site of perforation. Type 1 is perforation of the lateral or medial duodenal wall caused due to excessive pressure from the endoscope or its acute angulation. Type 2 perforation is periampullary injury, often associated with sphincterotomy or difficulty accessing the biliary tree. Type 3 perforation is injury to the common bile duct or pancreatic duct caused by instrumentation. Type 4 perforation is the presence of retroperitoneal free air with no evidence of actual perforation. This is usually an incidental finding and is of little or no clinical consequence. Question 27. You hear a discussion between two doctors about clinical manifestations of alpha-1 antitrypsin deficiency. Now, read the question. Hello, doctor. What are the clinical manifestations of alpha-1 antitrypsin deficiency?
Well, alpha-1 antitrypsin deficiency is associated with two major clinical manifestations. Emphysema, resulting from the loss of the proteolytic protection of the lung by alpha-1 antitrypsin, a toxic loss of function. Other clinical manifestations of alpha-1 antitrypsin deficiency include pancreatitis and an association with cytoplasmic antineutrophil, cytoplasmic antibody-positive vasculitis.
Question 28. You hear a discussion between a doctor and a nurse about autoimmune liver disease. Now read the question. Hello, doctor. What are the autoimmune liver disease?
Well, autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis are the three most common forms of autoimmune liver disease. Autoimmune hepatitis is characterized by high levels of serum alanine aminotransferase and aspartate aminotransferase, whereas primary biliary cirrhosis and primary sclerosing cholangitis are associated with predominant elevations of alkaline phosphatase, since they are cholestatic disorders. Primary biliary cirrhosis and autoimmune hepatitis are associated with autoantibodies in the serum, such as anti-nuclear antibody, smooth muscle antibody, and anti-mitochondrial antibody. Primary sclerosing cholangitis usually affects the extrahepatic biliary system. Thus, if it is present, abnormalities can be seen on imaging.
Question 29. You hear a discussion about brain chemicals involved in mood regulation. Now read the question. Hello, doctor. What are the brain chemicals involved in mood regulation?
Well, basically there are three molecules, chemically known as monoamines, that are involved in mood regulation. Serotonin has been coined the brain's feel-good chemical. Norepinephrine is another neurotransmitter connected with depression and how alert the feelings are. A low level of norepinephrine is considered to be associated with the brain fog that many people with depression experience, whereas low levels of dopamine in a part of the brain called the substantia nigra associated with Parkinson's disease. But there is much more to dopamine. In the frontal lobes of the brain, it is associated with complex thinking and problem solving. In fact, it is considered that the stimulatory effects of chemicals such as nicotine and cocaine are related to their effects on the dopamine-mediated reward centers in the brain.
Question 30. You hear a discussion about different types of gastric juices. Now read the question.
Hello, doctor. What are the different types of gastric juices?
Well, the food we swallow mixes with gastric juices secreted by special glands in the lining of the stomach. They include the cardiac glands at the top part of the stomach, the oxyntic glands in the main part of the stomach, and the pyloric glands in the antrum or lowest part of the stomach. Therefore, each of the glands contains cells that produce specific components that are called the gastric juices. Neck cells produce bicarbonate and mucus. Parietal cells generate hydrochloric acid. Chief cells produce pepsinogen, and enteroendocrine cells generate various hormones. Hydrochloric acid is a strong acid secreted by the parietal cells, and it lowers the pH level of the stomach to around 2. Hydrochloric acid converts pepsinogen into pepsin and breaks various nutrients apart from the food we eat. It also destroys bacteria that comes along with the food. Gastric lipase is another digestive enzyme made by the chief cells. It helps break down short and medium-chain fats. Amylase is also found in gastric juices, but it isn't made by the stomach. This enzyme comes from saliva and travels along the bolus into the stomach. Amylase breaks down carbohydrates, but doesn't have much time to work on the stomach because the acidity stops it. Intrinsic factor is secreted by the parietal cells and is necessary to absorb vitamin B12. This is essential for healthy nervous system function and blood cell production. Finally, the gastric juices contain water and mucus. The mucus is secreted by the neck cells and helps coat and protect the stomach lining from the acid environment.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear the discussion between a doctor and a nurse on the symptoms, signs, and causes of vulvovaginal candidiasis infection. You have 90 seconds to read the questions 31 to 36.
Hello, doctor. Can you explain how vulvovaginal candidiasis infection occurs, its symptoms, and its treatment?
Vulvovaginal candidiasis is a syndrome rather than an infection, and diagnosis of vulvovaginal candidiasis does not rely on clinical or laboratory criteria alone, but a combination of these two. Usually, vulvovaginal candidiasis is caused by C. albicans, but can occasionally be caused by other Candida sp or yeasts. Typical symptoms of vulvovaginal candidiasis include vaginal soreness, pruritus, dyspareunia, abnormal vaginal discharge, and external dysuria. However, none of these symptoms are specific for vulvovaginal candidiasis. About 75% of women will have at least one episode of vulvovaginal candidiasis, and 40 to 45% will have 2 or more episodes. Based on clinical presentation, microbiology, host factors, and response to therapy, vulvovaginal candidiasis can be classified as either uncomplicated or complicated. About 10 to 20% of women will have complicated vulvovaginal candidiasis, requiring special diagnostic and therapeutic considerations. Types of uncomplicated vulvovaginal candidiasis are sporadic or infrequent vulvovaginal candidiasis, mild to moderate vulvovaginal candidiasis, likely to be Candida albicans on immunocompromised women. Complicated vulvovaginal candidiasis are recurrent vulvovaginal candidiasis. Several vulvovaginal candidiasis, non-albicans candidiasis, women with diabetes, immunocompromising conditions, debilitation, or immunosuppressive therapy. By the presence of symptoms such as external dysuria and vulvar pruritus, pain, swelling, and redness, a diagnosis of Candida vaginitis is suggested clinically. Signs include fissures, vulvar edema, excoriations, and thick, curdy vaginal discharge. The diagnosis can be made in a woman with signs and symptoms of vaginitis when either a Gram stain or wet preparation of vaginal discharge demonstrates budding yeasts. Pseudo-hyphae, hyphae, or a culture or other test yields a positive result for a yeast species. Use of 10% KOH preparation in wet preparations improves the visualization of mycelium and yeast by disrupting cellular material that might obstruct the visuality of yeast or pseudo-hyphae. Examination of a wet mount with KOH preparation should be performed for all patients with symptoms or signs of vulvovaginal candidiasis. For patients with negative wet mounts but existing symptoms or signs, vaginal cultures for Candida should be considered. In case Candida cultures cannot be performed, then an empiric treatment can be considered. Identifying Candida by culture in the absence of signs or symptoms is not an indication for treatment, since approximately 20% of women harbor Candida sp and other yeasts in the vagina. However, postcoital testing for yeast is not approved by Food and Drug Administration. Culture for yeast remains the gold standard for diagnosis. Vulvovaginal candidiasis can occur concomitantly with sexually transmitted diseases. Most healthy women with uncomplicated vulvovaginal candidiasis have no identifiable precipitating factors. Short-course topical formulations effectively treat uncomplicated vulvovaginal candidiasis. The topically applied azole drugs are highly effective than niacin. Treatment with azoles results in relief of symptoms and negative cultures in 90% of patients who complete therapy. Over-the-counter intravaginal agents clotrimazole, 1% cream, 5 grams intravaginally daily for 7 to 14 days, or clotrimazole, 2% cream, 5 grams intravaginally daily for 3 days, or miconazole, 2% cream, 5 grams intravaginally daily for 7 days. Miconazole, 4% cream, 5 grams intravaginally daily for 3 days. Or miconazole, 100 milligram vaginal suppository, 1 suppository daily for 7 days. Or miconazole, 200 gram vaginal suppository, 1 suppository for 3 days. Or miconazole 1200 milligram vaginal suppository, 1 suppository for 1 day. Teoconazole 6.5% ointment, 5 grams intravaginally in a single application. Prescription intravaginal agents butoconazole 2% cream, 5 grams intravaginally in a single application, or turconazole 0.4% cream, 5 grams intravaginally daily for 7 days, or turconazole, 0.8% cream, 5 grams intravaginally daily for 3 days. Turconazole, 80 milligrams vaginal suppository, 1 suppository daily for 3 days. Oral agent fluconazole, 150 milligrams orally in a single dose.
Extract 2. Questions 37 to 42.
You hear a clinical psychiatrist called Dr. Evelina Horton discuss treatment for agitated patients in an emergency setting. You now have 90 seconds to read questions 37 to 42.
Hello everyone, my name is Dr. Evelina Horton, and in my presentation today I'd like to discuss an issue that I deal with daily, de-escalating agitated patients in an emergency setting. To provide some perspective on the issue, most patients who enter the hospital do so via the emergency department, ED. Many won't have received medical treatment yet, and that can make it more likely for these patients to become agitated. This can be exacerbated by their medical condition, a psychiatric illness, or other stress factors. Given the chaotic and crowded nature of the ED, it's imperative that we identify agitated patients early and apply non-physical de-escalation techniques as soon as possible. The provider who is going to initiate the de-escalation process should make sure that they create a considerable amount of space between themselves and the patient, and make sure that no one else is closer to the patient than they are. This not only gives the patient space, but also keeps the provider safe in the event of attempted physical violence. Ideally, both the patient and provider should also be able to leave the area without the other blocking their exit. Body language and tone of voice convey overall emotional state to a patient, so providers should remain outwardly calm throughout the encounter. When speaking to the patient, you should start by introducing your name and role in the team. You should determine how the patient prefers to be addressed and err on the side of being respectful. Use short sentences and simple vocabulary to enhance understanding. Leave a suitable amount of time between statements to allow patients to process what is being said. Sometimes repetition and enunciation may be necessary. Eye contact should be intermittent, so the patient does not think you're staring, and verbal responses should be calm without any hint of insults or challenges. Only one provider should interact with the patient, as multiple speakers can confuse an agitated patient. When the patient speaks, it's important to identify what their wants and feelings are, even if they may be impossible to address at this time. Try to consider things from the patient's perspective. Although they may be suffering under a particular delusion, such as paranoia, try to understand how the patient might feel or react if that delusion happened to be true. While we do not want to endorse these delusions, it's important to find common ground. For instance, if the patient is agitated because they think they are being followed, the provider can agree with the general principle, saying something like, "I understand that your suspicion of other people can make it hard to get the treatment you need here." It is also okay for a provider to agree that while they may not be having the same experience as a patient with an obvious delusion, they can believe the patient is having that experience and reacting to it. In addition, patients should be encouraged to make choices in order to give them a sense of control over the current situation and diffuse their overall aggressiveness. These choices should be realistic, however, and deliverable, as unfulfilled promises may backfire and irreparably damage the therapeutic alliance. Some of these choices can include medications to help calm the patient. A good way to state this is, "It's important for you to stay calm so we can talk. Can we provide you with some medication to help you feel less anxious?" Offering patients a choice between different medications or routes of delivery may also provide a feeling of control to the patient. Lastly, when the crisis is over, a key technique is debriefing both the patients and staff on how the situation went. The patient, now calm, may be able to provide more insights on what they were thinking and how they were feeling at the time. The provider can discuss coping skills or alternative options in order to prevent another aggressive incident in the future. It is also important to talk to staff as well, to gain any third-party feedback on the provider-patient interaction, what was appropriate, what helped de-escalate the patient, and any other changes that could be made to ensure patient, staff, and bystander safety. These techniques can be applicable to a wide variety of patients in numerous settings. They're not just restricted to the emergency department. Our hope is that providers will be able to de-escalate patients safely and effectively without having to resort to the use of physical or chemical restraints, which should be considered only when all other approaches have failed.
That is the end of Part C. You now have 2 minutes to check your answers.